that they fall under for needing a 504, and you have to provide these accommodations. And they always do. If we call, they're really good about it. An IEP is different. It requires that if your child needs special services like occupational therapy or physical therapy, or they need some sort of writing device because they can't write, so they need to type, things like that, then they would need an IEP, and they do get money from the state for IEPs. But private schools do not. Private schools can request funds from the public system to pay for IEPs, but it's like a first come served basis, and it's only if money's available, and we know how that goes. There's probably not a whole lot available. So private schools, I haven't had any issues with. They usually are really good about being accommodating. And then IEPs are, oh, did you have a question? No. Definitely not. So IEPs, we'll go over the different categories, but you'd have to fall under a list of, there's like 13 disabilities, and one of them is an orthopedic impairment and one is an other health impairment that typically, if you have scleroderma, you would fall under one of those categories. And the reason you would need an IEP versus a 504 is if they need special accommodations, like let's say they need physical therapy and they're going to do it at school, or they need a writing device. Special services that are provided to that student and not to any other student. And 504s are really just accommodations. So things that they do to level the playing field, like giving them 5 extra minutes on their assignments or tests, or allowing them to bring homework home and finish it at night and hand it in the next day. Missed absences for appointments and such. That's the difference. This just goes over, and I have handouts in the back too, so you can take them home and read that, because it really just goes over what I just said, the difference between the two. So I'm going to do it in a bit of like a side by side, so it makes a little more sense. So, and as I said, the IEP pretty much says that the student needs individual instruction, so individual services, care, and 504s just equalize the playing field. So and we'll go over what accommodations mean, but they're not getting anything that other students aren't getting, if that makes sense, even in a 504. And then in the eligibility requirement, there are 13 listed disabilities. I'm not going to go through them all because a lot of them are not relevant, because a lot of them are cognitive impairments and things like that, but there is an ortho impairment as well as the other health impairment, and your provider can provide a letter listing why they would fall under one of those categories if you feel like your child needs a special service at school. And we have done that for if they can't use a pencil when our patients can't write well, they will do a writing device, or somebody taking notes for them, or allowing their parents to document their homework at home, things like that are more IEP versus 504. Then the other criteria for an IEP is it has to affect their performance or their ability to learn. And pretty much if you have a chronic illness, it will affect your ability to learn, because it's a struggle every day. Yes, you have a question back there.
Yeah, is the 504 the same as the individual health plan?
So her question was, is an IEP or 504 the same as a IHP? I have not heard of an IHP, but I'm wondering if it's an IEP.
No,
Oh.
Individual education plan is different
Than a health plan? I don't know. That's a good question.
We have one for our son. So I know it falls under 504, but it's one of the accommodations that could be placed for 504. So it's things that your child has individualized health benefit as well. So it's like special accommodations, like if he's tired, he can go to the nurse's station, he can use the nurse's bathroom, he can, it has a lot of the same considerations
Right. Yeah. And those would all be listed under a 504. It may be just like what, I don't know, maybe some schools might have it as a additional form. I don't know. I've never heard of it, but I will look into that for sure.
Yeah, no, we also were offered, it's called an IHP, an individual health plan, I believe. And I don't know if this is new, but we were also told during our 504 meeting that an individual health plan might be more appropriate for my daughter's needs, which are along the lines of what's been discussed, gym needs, things like that.
Right. And do they have legal obligation to follow an IHP versus a 504 or they do?
Yeah, and like in my son's, it's things like there's communicable disease. So like
Right. Informing you if there's, yeah, yes. Yeah. We typically list that as an accommodation in our 504s as well. For 504s, you don't have to fall under one of those 13 disabilities. It can be anything that you think is a concern for your child, essentially. So anything that is difficult for them, you could list as something that they would need a 504 for. Like if your child breaks their leg and they might need a 504 for like 2 months or 3 months, and they do those short term like that. And then the 504 doesn't have a review period typically. Most schools review them every year, but there's so many that often they don't because they don't have to. But IEPs do have to be reviewed every year and then reevaluated at once every 3 years. So there's more regulation with them. In an IEP, the participants are a parent. There needs to be a general ed teacher, a special ed teacher, a psychologist, and a district representative. And then the 504s are less specific. It's kind of like they should have a parent and somebody from the school and maybe a principal. So it's just not as it's not as strict of a guideline, I should say. IEPs are in writing. The 504 does not have to be in writing, but they need to have it somewhere that they need accommodations, support services, and all that stuff. But it doesn't have to be on like a special document. As I said, IEPs are funded by the state, but 504s are not. And then if you feel like you're not getting your needs met, you can dispute and you can, go to the officials above the school and even higher than that if you feel like you're not getting your needs met. So to be evaluated, this is the criteria for being eligible, and it just essentially says an individual with a disability, which means that they have some sort of impairment that limits one or more of their activities. And so obviously our kiddos and your children would fall under that category, right? There's something that they're probably limited in. And even if it's just that their hands get cold and they can't write, things like that. So implementation is different. I kind of went over that. The IEP and the 504, they just explain the how or the why, what the child needs. It should include functional activities and socializing activities, services, things like physical therapy, extra instructional courses, and homebound tutoring. Those would be IEP services. And then accommodations are changes in how a child shows what they have learned. So extra time, as I said, things like that. Modifications are just adjustments to how they're learning. So maybe the teacher gives, the kids take notes, but the teacher gives them their notes on the computer at home or something, like in a Google Doc or something like that, so they don't have to write their notes all day. And follow up, make sure the school's accountable. As I said, they should follow up, follow through. If you feel like your child's needs aren't being met, then that needs to be a conversation. Reach for the stars, and that just put everything out there right away. If your child ends up not needing it, that's okay, but it's always good to just have it as a baseline so that if they do have a bad flare or they're really not feeling well, that you've got this to fall back on. And they may not need it the whole school year, but if they do for 1 month, as providers, we often get phone calls in the middle of the school year where they say this child's missed 15 days of school. They tell us that they have this problem. We don't know anything about it. And it's really hard to do it on the back end, and say, yes, they do. And it's a lot more difficult to make up the work, to do all that. So try to get it done in the beginning of the year, even if you don't think they'll need it. These are some of the IEP services that may be needed, that if you felt like your child would need an extra service like that, then you would ask for an IEP, and they would need an evaluation, and it would be a very set, they're evaluated by the school and by the district representative, and you have to get letters and things like that. But if you feel like your child needs something like that, then you should go for it, because in the end, they follow them all through school, so you don't have to redo it. You have to it has to be updated. But once they have this 504 IEP, it follows them all the way through school, and even into most colleges will take them as well. So it's just nice to just have it, and so it follows them all through. These are just like some of the accommodations. So in elementary school, different types of scissors, maybe different types of pencils or pens. Extra textbooks, so you don't have to carry a big backpack back and forth. Oftentimes schools will do that. Time for assignments, or even like shorter assignments if they have 10 pages of math homework. Like, is that really necessary? Maybe they have an option to do, or they do it over the computer instead of writing it all out. Extra time for tests, maybe breaks during the day. So another issue we've had is that they don't want the kids to have snacks at school. So we'll say they should have been able to keep like some snacks in the nurse's office, because their meds can make them feel sick to their stomach, or they are just really tired more often. They might need to take a short break during the day. So we do tell the schools that now, that they need to be allowed for extra water breaks, snack breaks. And sometimes we'll ask for early release for lunch or classes if they're in a huge school and a large campus, so that they have extra time. Like if you have a 5-minute break between classes, you got to go to your locker and you're not moving very quickly, then you're tardy for every class. And that this way they could either leave early or be allowed to come late. And then note-taking support, as I said, sometimes they'll have people at school that take notes for them, or their family can do it at home on assignments. And that's worked out well as well. Why is this important? I've seen it in our office, because the reason it became important to me is because we've had patients who say, we don't need anything, the school's doing great, they're doing a great job. And then the next year they say, well, we thought it was really good, but then the PE teacher that did this, or her science teacher said she doesn't understand why one day she looks great and the next day she can't participate. Just knowing that this is an autoimmune disease, and that some days they look great and feel great, and the next day they might not look great or feel great, and that it is this kind of roller coaster ride. And so I think that's one of the reasons why it became really important to me, because I was doing it on the backside after the student had missed a bunch of days and were behind on homework and failing classes. And I just felt like we could do a better job on our end informing families of what they were are eligible for at school, and making sure the school is informed and who to inform, because often it ends up at a desk in a office somewhere and doesn't get to the school nurse. And so I've been trying to really communicate with our school nurses in Denver directly, and so they have my phone number if there's any problems or questions or concerns, and they know who to contact, and I know who to contact. Attendance is really important, which is why schools have a fit if you pull your kids out of school. So if they know ahead of time your kid's going to be missing, a day every week, or 2 days every month for an infusion or a procedure, or they get sick more often, then if they know ahead of time, it's not as much of an issue. And maybe they can send homework home, or you can pick up homework, things like that they don't normally do for other students. The other thing is services at school have shown to improve performance. So when kids are using their 504s and their IEPs, it shows that they have improved performance, because they are able to be at the same level as their peers versus before they were kind of trying to keep up and keep up and keep up, but now they're sort of at the same level, and so their performance improves. And another reason I feel like this is really important, because schools are where kids are kids, and it's really important for them to be there so they can feel like a normal kid and feel like, you know, because they can do all the things. It just might be that they're slower or they need more time, but socialization is so important. And when they start to miss a lot of days, it becomes easier and easier to not go. So we really try to encourage our kiddos to be at school as much as they can. And as I said, school is not just about academics. It's really about being in relationships with your friends and the teachers, and having people around that you trust and that feel like they're supporting you, not just your parents, because they have to do that. But if you know that the school's really supportive and empathetic and sympathetic, then I think the kids feel much better at school. We've seen that when we educate the school and the nurse is aware of what's going on and the teachers are, that the school year goes so much smoother. The teachers just are, I feel like, much more empathetic and will provide extra accommodations if they need to, knowing that, you know, what they're struggling with. As we know, if your child has a chronic illness, they're more likely to maybe have depression or issues with feeling rejected by their peers. And so school support and maybe them telling their peers what's going on, they don't often want to, but if they do, sometimes it helps with the relationship concerns and depression concerns, because the more support they have, the better. We've found in some of the research that I've looked at that having companionship and peer support decreases their risk for depression when you have a chronic illness. And then there's also the struggle for wanting to be really independent at school but needing help. And so, you know, kids always want to do everything themselves. I have a 6-year-old and she doesn't want me to even come anywhere near anything. So I think that, you know, kids don't always want to have that extra support. It kind of sets them apart sometimes. They don't want to be different than their peers. But if people around them know what's going on, I think they're more supportive. I think kids can be really mean, but I think in general, kids are really compassionate and want to know what's going on and want to be kind. Then these are some of the perspectives that the kids, when I looked through some research articles about adolescents and children who have juvenile rheumatic disease. So this encompasses a lot of our diseases, not just scleroderma. So lupus and arthritis and some of the other diseases as well. These are some of the concerns that they had about school and just their chronic illness in general. So they did not want to be different. As I said, they don't want to be set apart from their peers. They want to, you know, do everything everybody's doing. So striving for normality. So not wanting to, you know, take more breaks, wanting to be able to do the mile, but maybe can't quite do it. One of the things I've asked some of the PE teachers is, like, if they're going to walk the mile instead of run, is there like another student who also can't run the mile, and can they do it together? So they have some companionship and some support instead of them like walking the mile by themselves while everyone else is running, because that feels very isolating. And so allowing them maybe to have a buddy that they get to walk with instead of running, because really, how important is running the mile? I just don't really know why that's so important, but apparently it really is, because we hear it all the time, like every week. They make me run the mile. I'm like, why are we running the mile? Like, why is that so important at school? If they walk it or run it, who cares, you know? Stigma, misunderstandings. So, you know, kids, I think if the teachers and the kids are more aware, then there's less misunderstanding. I think that often when you have a chronic illness and teachers don't know what's going on, they can have misunderstandings as well. There's like another research I looked at that said that teachers, if they weren't educated on the child's illness, they would jump to conclusions that they were faking, or they weren't, that it wasn't real. So, and then as soon as they were educated, they gave them an hour, you know, presentation, and then after that, they they reevaluated, and the teachers were much more empathetic and sympathetic. So then I think also our kids with chronic illness, and especially with autoimmune disease, there's a lot of uncertainty. Like, today I feel great, and tomorrow I'm going to feel worse, or will I get better, or will I have to take these medicines forever? So having some support's really important for that. Including them in managing their own treatment. So knowing what their meds are, what they take, how often they take it, what it's for. You know, some of the medicines are different for different things, so knowing what the medicine is for. Obviously, this is age-based, so if you have a 2-year-old, you would not be doing that. But if you have a 9-year-old or a 10-year-old, they should definitely start learning what their medications are, and you know what it's for, and things like that. And then, as I said, the desire for knowledge. I think kids, even the patients and their peers, all want knowledge. And I think we've had some of our students who one of us will go with them and teach them the class about their disease, or we've just given them information and kind of given them support and doing it themselves, and they will go in front of their class and I don't know what that is. Wants to like open Epic. So then the other thing I think schools could do a better job is of providing support services like counseling programs, or even like a breakout group for maybe some of the kids who have chronic illness. It doesn't have to be the same chronic illness, but you could have a kid with asthma and a kid with seizures and a kid with scleroderma and arthritis and lupus, and just get them together and see if school's going well, do they have any concerns? And that's just more support people that can kind of understand what they're going through. And then, as I said, give the child an opportunity to talk about their disease in class. Obviously, they don't have to, but I often encourage them and say, we can help you, I can coach you, and then we've gone with the student and done it in their class with them, and they really love that. So, and I think they feel like the students are much more supportive and empathetic after that. Immunizations are a big topic at the school. A lot of our patients aren't fully immunized and can't be. So we always talk about herd immunity, because that's why everyone else should be immunized, so that they keep all the other kids who can't be immunized safe. And the knowing, as she said in the back, that if there's a communicable disease at school, they should inform you, because they could be more likely to get sick. And if they're not fully immunized and there's like a measles outbreak or chicken pox or something like that, that should be something the parents are informed of. So we always let the school know that as well, so that they will inform the parents. Takeaway points: the IEPs and 504s are contracts that have to be followed through. So please make sure that everybody's accountable, including your healthcare providers. So if the school is asking for information and they're not providing it, we've heard from other families in the past that the rheumatology office says, oh, the primary care office should be providing that for you. And I feel very strongly that that's a specialty care. If your child's receiving specialty care, those letters should be coming from their specialty care practice, not from their primary care provider. And they should have our phone number and our contact information. And so when you go back, I would highly recommend just talking with your healthcare provider and giving them the school's name and the nurse's name, and that way they can communicate if they need to, if there's any issues. I think communication is by far the most important part of with school and with your healthcare provider. And then, as I said, include the medical team. And that's it. Any questions? Sorry, I talk really fast. Does anybody have any questions? No? Yes.
My daughter is 504. She's now in high school. And if they miss more than 7 days, they go to a pass-fail grade.
Oh.
Is there a way a doctor can just write an excuse for the whole year and just say, hey, she's keeping up on her grades, she's got all A's, she's doing what they want me to get a doctor's note for every time she's absent?
so the way we usually write it in our office is that they may have increased absences. Please don't hesitate to call if the child's missing, multiple days of school, to call us, because then we can reach out to the family, because if they're having a flare, they're not doing well, we should know that as well. So if we haven't heard from the family, then we can call them as well and say, is there, what's going on? Can we help? We often do letters for multiple days. So the family will be like, we missed Tuesday and Wednesday last week and Friday this week, and then we will do that. We don't typically write a blanketed excuse for absences, just because we really want them to go to school. So we would love to hear from the school if they're missing school. So we don't, and so that's what I usually say, is to call us if they're missing, if they're concerned about the amount of days of school they're missing. And we've not had a problem in the past, but I don't think a doctor's note for every missed absence is.
There's times where it's just, I just took my medication and
Yeah.
I feel like,
Terrible. Yeah.
so. All right, thank you.
Yep. Anything else? All right. Thank you.
Is it just, do I just like X out? Escape?
Trick or treat.
Where did mine go?
A little treat for you. Thank you for coming. Yeah, my pleasure.
Thank you, Carrie. Back up again is Dr. Katherine Moore, who is going to talk about transitioning from juvenile to adult care as soon as we find her presentation.
I don't know where I left it. I'll let you.
Or he's actually going to load it up here. And remember to repeat questions.
Sorry. There's the. Okay. Hi again. So the next talk, we're going to chat a bit about the process of transitioning care from pediatric rheumatology to adult rheumatology when the time comes. It's a topic that not everyone in the room probably has, a 17, 18-year-old. A lot of you guys have much younger kids. But honestly, the one thing that we can't stop in life is time. And so ultimately things do keep ticking by. And I think the other thing that's really important is transition. By definition, I'm not using the word transfer intentionally. It's transition. It's a process. It's not a 1 second you're in this clinic, the next second you're in that clinic. And anything that's a process takes time. And so we actually start talking with our patients in their kind of early tween, early teen years, just in terms of, hey, do you know what meds you're on? Do you know what your condition is? And it's a process that builds over time in order to make things as smooth as possible, which is why even if you don't have an imminently, 17, 18, 19-year-old, I think it's still actually relevant for most folks. So today we're going to chat about, why do we even have a whole talk on this? What is the issue? And then kind of approach how some places are approaching this, kind of a general sense of approaching the timeline, some of the things that can potentially go wrong, because it's easier to avert errors if you know about them ahead of time. And then I'll mention some resources that are out there to kind of help with the process too. So again, just super brief overview, 2 different types, but regardless of what type of scleroderma you have, for everything, it is a chronic illness. There's a chance of recurrence even in the localized patients, where there are definitely a large number of patients where it is a quote unquote one-hit wonder. That being said, you have cumulative effects from medications. There is always a chance of recurrence. There is ongoing monitoring, and especially for the systemic patients. You have, complications from past disease. We talked about the mechanical issues that can happen with joints and other places in the body, as well as complications for meds. There may be people who've been on long-term immunosuppression or long-term steroids and have complications just from their medications alone. So kind of all of this together means that just because you magically turn 18, your problems do not go away. And at some point, we're going to need to find an adult rheumatologist. But transitioning it's more than just another provider too. I mean, there's, some practical aspects, and then there's some emotional aspects. I mean, even look at the two different, this is the University of Colorado Hospital just across the courtyard, their rheumatology clinic. You're in Children's, there's colors everywhere. There's hippo-shaped couches and, therapy dogs wandering around the hallway and a gelato shop in the lobby. And you go over to the university and it's like stark white walls with the same paintings from 1950 that have probably been up there without ever having been changed. And so which is intimidating if you're, a young adult that's suddenly, facing all your new healthcare needs, and then all of it, like warm and fuzzy is warm and fuzzy for a reason, right? And, it's only one of many changes. For a lot of these kids, they're off at college or they're having their first full-time job, and there's a lot of simultaneous changes in addition to just the medical things. It's an entirely different, model of care too. For, you guys, when you see your own healthcare provider, reflect on that compared to when you go for your child's healthcare. In pediatrics, it's very family-centered. The family actually by law has to be there. There's follow-through. If you miss appointments, it's not just too bad, so sad, you missed an appointment, you're not taking your meds. There's legal implications. If you're in the adult model, it's very patient-focused. Sure, others can come along, but you yourself are the responsible patient. And so it's also, there's not people kind of following up on you. Medical insurance may be changing during this time, and there's been numerous studies that have actually looked at the transition period of young adulthood, and over, whether it's rheumatology illness, whether it's other specialties, congenital heart disease, sickle cell, cystic fibrosis, inflammatory bowel disease, you name it, across the board, that period of time between like 18 and 24 years of age is associated with worse disease control, worse flares, more hospitalizations, and overall worse outcomes. Some questions to reflect on too, especially those of you who do have teens, is how many of them actually fill their own prescriptions and know how to do that? How many of them can actually name their meds and potential side effects to watch for? How many of them give themselves their own medications or call the doctor's office themselves to schedule appointments? I'm not saying your 10 and 11 and 12-year-olds need to be doing all of these, but kind of having it at least on their radar, and especially as kids get to be older, mid to older teens, maybe starting with you're right by them, next to them, so if there's questions, they have backup, but more and more getting them used to it while you're still there so that when they're actually finally on their own, it's not completely bewildering. Another kind of getting at, is it really a problem? So Boston Children's Hospital actually did a study, this was in lupus patients, and they looked at lupus patients who'd been diagnosed in childhood and followed in their pediatric rheumatology clinic, and then they looked at their next follow-up between the quote-unquote transition period when it was supposed to be see an adult provider in like 3 or 4 months, and instead it was closer to about 8 months before that first appointment actually happened, which is more, about 3/4 of patients had major gaps in their care. So what some places are doing to address this, so actually in Boston, they have a center, it's called the Center for Adults with Pediatric Rheumatologic Illness, or the Capri Center, and it's staffed by a med-peds trained adult rheumatologist, so he's had training in both internal medicine and pediatrics. They have peds rheumatologists, adult rheumatologists, and by ancillary staff, that's things like social work, PT, OT, all of those other services. And it's specifically designed for young adults in that kind of college-y age group from kind of 18 to early 20s. So not only people that have been followed in their own pediatric rheumatology clinic, but because, I'm from Boston, so I can definitely attest to the fact there's practically a college on every street corner. It's kind of like Dunkin' Donuts. You can't look and not see one. And so there's just a really large population of young adults living in that area. There's a very similar type program in Vancouver that's kind of set up similarly. In Columbus, they actually they kind of published where it's not a separate transition clinic per se, but they have a transition program where people in this identified age range had very structured visits with a social worker to provide education. And then when they did follow-up on those patients, about 40% of the ones who were involved in the program had successfully transitioned, whereas only about a fifth of the patients overall were successfully transitioned, which still says to me more than 50% are having gaps in care. So there's obviously still work to be done, but also it underscores that preparation helps. But for many pediatric rheumatology programs, there's not a formalized program for the transition process. It can be super variable from provider to provider, depending how passionate one person is on it, depending how complex the care is and how many other issues are going on. Also depend, if it's a patient who's followed by derm and rheum and GI, and you start naming the subspecialties, it can get even more complicated in terms of those discussions. And so there's these transition checklists that when I was in my fellowship training, we actually had a transition kind of packet and checklist. We're in the process of making one of those here. I still use the one I used previously. But things like that are still super variable. The Arthritis Foundation, I think I mentioned earlier, in terms of the camps that they do, they actually have a teen retreat each summer in some locations across the country that's for 14 to 18-year-olds. And here in Colorado, it rotates at a different college campus, so they get to stay in the dorms. And it essentially is kind of like rheumatology teen retreat for kids with a number of rheum illnesses. And part of that is we have a transition panel where one of our adult rheumatologists and I kind of co-lead it and kind of chat and do Q&A and informal stuff and transition Jeopardy and all sorts of fun stuff. In terms of the timing, so age is a continuum, obviously. I think it's ideal to start at least broaching the topic, like I said, kind of early teen years, and then kind of the mid to late teen years in high school. Start thinking, where do you think, you're not laying anything in stone, but where do you think you might end up after high school? Are you going to be staying local? Are you going to be moving? Start chatting about, hey, in the adult world, this is how they do things a little bit differently than we do here, just to start kind of putting it on people's radar. Towards kind of senior year high school, as you're getting kind of close to the end, it's ideal for us to try to model that adult model of care. For example, parents aren't, maybe have the parents wait in the waiting room for a good chunk of the visit and then come in at the discussion so that everyone's on the same page. Granted, timing in a busy clinic sometimes makes that more difficult, but in an ideal world, that would be lovely to do. I think that's the advantage of transition clinics that are specifically designed around that, but as best we can do to try to model that, I think is helpful. And then in that 18 to 22-year-old range, actually having the formal transfer of care. And I think it's also important to think it's not just your rheumatologist who you'll be transitioning, but also unless you've been followed by a family practice doctor who sees people across the age continuum, it's really important to have the primary care also, if you've been seeing a pediatrician, be sure that either your pediatrician is going to still keep following you, and just be sure that piece doesn't get fallen off the radar as well. Another way to think about it, and this is actually, there is a website out there in the handouts at the very end. It lists a lot of website resources, but there's one called Got Transition, and this is the way they actually lay it out, is they call that those early teen years kind of the time for discovering and tracking, and we'll talk through this stuff in more detail, and then kind of the practicing in the later teen years, and then finally really taking charge. And so from the discovering and tracking, what they're referring to is kind of learning about your health conditions with the goals, can I describe my illness and how it affects my life? Can I name my medications? Can I answer at least some of the questions that the doctor is asking instead of just turning to mom and dad for every single answer? And when you're at home, can you describe symptoms if you're not feeling well? From the tracking standpoint, it's not necessarily that at age 12 you're expected to keep track of all your medical information. Most adults can't do that, but at least kind of generally being aware of where is it kept? Is there an online portal, or do we have a folder that has pertinent information so that if we're on vacation and something happens, We don't have to explain everything from ground zero. Is there something that I need to bring to all of my appointments? And then little things that kids can start taking charge of, though, is managing medical things at school. Are they on methotrexate? So it's really important for them to wear sunscreen when they're out in the sun. And can they remind the school and the nurse, hey, I need to wear my sunscreen? Are there medications that they need to take throughout the day that instead of someone chasing them down, they know the timing of it? Do they know that in PE, even if they really want to keep up with all of their friends, this concept of self-pacing where they're the ones who get to kind of call the shots, which is often how I approach PE, is unless there's a condition where there's actual danger, usually I like to rest it in the kind of child's hands, that I don't want to give a blanketed gym excuse where it's like you can't do anything, because I want kids to be able to do the things that they can. And if they're having a great day, that's fantastic. I just don't want someone behind them cracking the whip, making them do stuff when they're super uncomfortable. So being able to have the assertiveness to say, hey, I'm not up to doing that. And then in addition to kind of letting mom and know how they're feeling, know what are the warning signs, like what are the things like, hey mom, I think I probably do need to go back to the doctor. Hey dad, something's going on. And just starting to have that awareness of how their condition might be changing. Hey, I've noticed that the spot on my leg, I was in the shower and it's more red around the edges. And I feel like you guys told me that if it started to get red or purple, I should let somebody know. Those middle ages, the practicing independence. So it's both for the patients and for you guys too, because letting go is really hard. And to be completely honest, it's for us as doctors too, because we, especially in pediatrics, tend to be very kind of ownership of our patients and very invested. And so it's kind of the entire team starts to learn, okay, how do we let this person have some independence? In addition to just knowing that there are medical records somewhere, are they able to actually start keeping track of some of that stuff themselves? Maybe starting to practice to call the pharmacy or use a pharmacy app when they're low on their refills. Starting to really have the goal of answering most, if not all, of the questions that are asked during the actual doctor's appointment itself. And then calling and emailing the doctor yourself if there's issues. Here at Children's, and this is something that's a little state by state in terms of age of kind of medical independence, but here at this hospital, the EPIC system, which is our online portal, starting at age 14, there's separate accounts. So before age 14, parents and children are kind of combined, so the parents can email us medical concerns about their child. But starting at age 14, the kids can have their own separate medical portal, so they can actually ask us questions themselves independently. And like I had mentioned before, just starting to think through what are those changes that are going to start to happen once I turn 18? How do the consequences differ from when I'm younger? When you're younger, again, you miss an appointment, we follow up. We're like, what happened to you? Why didn't you come in? I see you didn't refill your meds. If you're over 18 and you miss an appointment, not only is it kind of okay, that's too bad, it's your responsibility to call back. But a lot of places have policies that if you no-show for 3 or more appointments or however many appointments, they won't even see you anymore. And so recognizing that there are actually differences with that. Start to think about, how do I find a new provider? Because if it's going to be someone here local, is it going to be someone out of town? In rheumatology, it's a really small world, so we have friends all over the country, all over the world, so we can usually help you guys find somebody, but it sometimes does take some legwork, and it also requires scheduling things ahead of time, so just starting to do some of that scouting in advance is super helpful. I think one step even further with the medications, we talked about know your medication list, know potential side effects. But also, I think the other piece is, are there medications that you shouldn't take because of the medications you're on? So if someone's on a scheduled naproxen or ibuprofen, if they get a headache, can they just get the aspirin that their friend happens to have in their backpack? Like, kind of knowing, are there things that I actually should not take is just as important. And I think the other big piece is starting to question what's going to happen with insurance, because some people are going to stay on their parents' insurance until they're in their early 20s. Other folks are going to try to get college health plans. Other people are on Medicaid, but then if you're switching states, you may need a new Medicaid plan. So, there's all sorts of potential directions insurance can go, and just starting early to think about some of those so it's not a rude awakening the day you turn 18, suddenly you have no health insurance.
How is a 17-year-old supposed to do that?
With our help. I mean, that's the thing, is not on your own. So it's these are all kind of conversations to have in clinic with us, kind of with parents too, hey, what is your mom and dad's insurance policy? Are we able to kind of stay on the same plan? And so it's definitely not kind of all on the child. This is more kind of group family provider discussions about.
I mean, if you're in Colorado,
Yep.
you go to school outside of Colorado, your insurance in Colorado doesn't cover.
Correct.
So
And that's the thing, is just thinking about that ahead of time so that it's not the day, so, that's part of the, hey, I think I want to go to school somewhere else. Just start thinking through, hey, when that starts getting even more imminently closer, we need to be sure that there actually is a plan in place.
like Boston and Vancouver, does your group do that? Will they work with somebody who's one of your patients who's 16, 17, or 18 for them to be able to make informed decisions on where they might get the best care and what the different issues that they might like insurance or
We don't have a formal transition clinic that's like kind of a separate clinic for that age. What we do here is kind of in those late teen years, we just start kind of really talking and putting a plan into place and kind of working through those issues. What we often will do is, if you go to school out of state, we will see you, as long as things are medically stable and you're not going to be like imminently needing people on a regular basis, we'll often follow people like when you're home for fall break and home for Christmas break and spring break, and kind of do intermittent visits kind of throughout the college years. We typically don't take new patients over the age of 18 just because you're so close to needing an adult provider anyways, that's just multiple transitions within a short period of time. And so if someone's over 18, we usually have our adult rheumatology colleagues who are literally like across the courtyard that way, who we work super close with. And there's a few of them who have a specific interest in kind of young adult populations. We're actually in the process right now of trying to start up a transition clinic. But right now, if it's a patient that we've been following, then we can follow them through college. If it's a brand new patient, we typically won't see over age 18. But we do, with our patients who are kind of nearing that age, is work with the families and in trying to help figure out what are the insurance changes going to be. The actual like kind of taking charge, the transition process, making that change, I think the other thing to kind of keep in mind when that comes is knowing like what information are they going to need so that you just don't show up on somebody's doorstep with them having absolutely no medical information. Yes, medical records will send your medical records, but that's like for some patients, if they've been followed chronically with us, their medical records can be a huge stack or lots and lots and lots of documents. And for a brand new physician seeing someone for the first time, that can be completely overwhelming. So keeping us in the loop before that transfer is made so that we can actually kind of write a summary letter so that your new provider has it kind of in one place. Yeah.
So would it be wise to ask the pediatric rheumatologist on someone that we could possibly transition the child to?
Yeah. So what we, and I, again, so here I can't speak for everyone, but what we like to do is, again, start these conversations early and help identify, depending on where the person is gonna be, identify who are some, options in that area. If it's here locally, we personally know much more and we can better help kind of cherry pick who it's going to be. If it's someone else, then we usually will kind of rely on colleagues and networking to identify someone. So that person and that appointment is kind of set in stone while you're still in our care. And then the other big piece is you're kind of still ours, so to speak, until that first appointment has actually happened so that you don't sort of fall between the cracks. But we do help identify a new rheumatologist, and I personally like to reach out to that person either by phone or by letter or email before, well in advance, with just kind of a summary that just says, hey, current meds to date, current complications to date, so that everything's kind of in one place with the highlights, and then they can kind of flip through the rest of it to see all the nitty-gritty. But yeah, we definitely like to work with you guys.
Taylor, my daughter is to be seen at University of Florida until she's 21.
Okay.
They said they'll keep her until she's
Yep.
but then after that.
after that. And that 18 to 21, that I think is the grayest area and probably is practice to practice dependent. Some places have bigger hospital policies in terms of strict ages of cutoff. Others are more variable. If it's somebody who's staying locally, we have a lot of kids who go to college here in Colorado. I am totally fine following them kind of through that time. If they're going to school in California or Boston or somewhere else, and their health has been so precarious that I don't think they can go to winter break without having an appointment, then we really do need to put something into place so that there's somebody locally where they're going to be going. The other thing is to think about, especially if you've been followed at an academic pediatric center, typically places, like a university setting are going to have a parking lot that's pretty close to the hospital, and x-ray and lab and everything is within the same building. And if you're also seeing other subspecialists, it's in the same place. But if you go somewhere and you're now seeing, a private practice rheumatologist, they may or may not have labs in their building. They may or may not have x-rays in their building. It may or may not be a multi-practice. So it may be that you go to a different building for rheumatology and dermatology and nephrology or cardiology. And so if it's the more subspecialists that are involved, I think those are the cases where it really is more beneficial to be in an academic setting where everything can kind of be under one roof. But that's the other thing that goes into picking that new person is what is that practice like, and knowing ahead of time, how am I going to get there? What's their cancellation policy? What do they need to have in advance? I think I mentioned before, I think most important to prevent gaps in care is knowing just because we've used the word transition, that doesn't mean goodbye forever. We're cutting the cord this appointment. Like, we still consider you our patient at minimum until that first appointment with your new provider. If that new provider appointment, if it doesn't work, we all know that there are certain personalities that just do not mesh, and there's nothing worse than going and seeing a new adult rheumatologist and being like, I don't ever want to see that person again, so I'm just not going to go to rheumatology, or I'm going to cross my fingers I find some other person down the road. Let us know if it doesn't go well so that we can help identify other options and kind of work through things too. I think bottom line, we just don't want kids to fall off the radar. We talked a little bit about thinking about insurance ahead of time. I think the other thing is this is all, it's nice to draw a little arrow up there, but it's not always linear. Progress is you go 2 steps forward, 1 step back, 1 step forward, 5 steps back. And it's kind of a process which kind of underscores the importance of starting early, just thinking about these things so that all of these arrows in different directions don't start when you're in the 18 to 22-year-old age range. Pitfalls. So I think, thinking about things ahead of time is important to prevent things from falling between the cracks. So the most common themes that we see: inadequate preparation, not knowing their disease. Someone says, "What's wrong with you?" I have a rash. Know what your diagnosis is, know what your medications are. I think a huge thing too is, again, that adult healthcare system that can be completely overwhelming, and you miss an appointment. Let's say you have finals and you're stressed and you forget about it, and then nobody from that office calls you to follow up on it. Transportation, how are you going to get there? Copays, mom and dad used to come along and they had their wallet, and do I have a credit card, or do I have a copay, or how does my insurance work? And just kind of the whole separation anxiety from the standpoint of, again, the brightly colored walls of a children's hospital to the adult world. So in terms of preventing these pitfalls, again, start time early is good, but early sometimes isn't possible. Let's say we see a patient for the very first time when they're 18 or almost 18. We don't have, 5 years of preparation. We've got, a few, 5 months, 6 months, or, potentially a few years. But start time kind of depends on how long we've known you. We mentioned complexity of care. The more specialists that are involved, the harder it is, because it's ideal to have everyone in some cases, it's ideal to have everyone move together. In other cases, honestly, I've had some patients where we do it. This is mostly when it's at the university, because our 2 computer systems can actually talk to each other and we're all considered the same. It would be a little harder if this was out of state, but sometimes for some patients we do it in pieces. And the analogy I keep in my mind is like when you move, first you got to get your internet set up, and you've got to get your cable set up, and you're going to take the heavy stuff, and then you probably have a carload with all the little piddle that you kind of bring over, and then there's someone who goes back at the very end and looks through all the drawers and makes sure that nothing was left behind. Sometimes that actually model works better to make sure that issues, especially for complex patients, don't fall between the cracks. The other thing is, how often are you following up with us? If things are so stable that you're seeing Peds Rheum once a year, then suddenly, that once a year, it all impacts the time frame of getting over to the adult world. Talked about knowing your medications. I think one of the big things with meds, and right at the bottom, is also, yes, it's great to know how to refill your meds, but there are certain meds like methotrexate that you need to have labs for on a regular basis in order for it to be safe for those prescriptions to keep going. And just knowing that if you don't come and you don't have follow-up and you don't have the labs that you need, we can't just magically indefinitely keep refilling medications. Talked about, failure to make that first appointment is another big thing that a lot of adult rheumatology practices, if they're booking out 3 or 4 months, you can't call and expect to be seen in 2 months. So kind of, again, underscoring planning and starting early. We talked about no-showing. We talked about transportation. So a couple things just to leave you guys with, and this should be in the handouts just so you guys can reference it. But there's a few websites that actually talk through the transition process and talk through all of these kind of potential pitfalls that we've chatted about. How do you plan insurance changes? How do you find new providers? What's the most critical information for you to bring with you? This is one from the Arthritis Foundation. GOT Transition is the model that I was basing some of those arrows on. And, other websites. The other thing, and this is not just for your patients, but for all of you guys who have smartphones, which I'm guessing is most of you, do you know about the emergency app in your phone? Show of hands for people who know that there's an emergency medical information application that you don't have to download, it's already there. So if you have your phone on like the off lock screen and you just like press the button to turn it on, this is for the Apples, I'll do Droid in a second. But when you turn it on, so look at the bottom screen here, like this one is like when you first turn it on, in that bottom left corner, that little button that says emergency, that's not just to call 911. If you press it, and I promise it's okay to press it, 911's not gonna come, you get this next screen that then says medical ID in that bottom left corner. And if you click medical ID, this top right-hand corner pops up and it can list diagnoses, medications, contact information for your doctors, contact information for your family, things that people can access while your phone is off and locked. So and most EMS providers and hospital ERs and physicians know that it's there. So if you're in a medical emergency, people can access your phone to get the pertinent medical information. And in order to enter it all, it lives under this health app, the little white thing with the red heart that should be automatically on everyone's phone. For Droid, it's called ICE, which it's the instruction in case of emergency. So both of the major phone types have it. And then also in your packets are just, especially as teens are practicing independence and going off, keeping organized is super important. So there's apps that can make you send reminders for taking pills, help keep track of appointments in the context of a busy school life. And just kind of overall, in this day and age of technology, let it be your friend too. Sorry, that was kind of rambling. I think I was channeling my inner East Coast and talking a million miles a minute there. But what questions? You guys have had awesome questions so far. Anything else? Okay, you know where to find us. And I think I'm turning it over to dermatology now, right? Yeah. Oh, there you are. Hey.